Hi, it is time to talk about another type of abnormal patient-ventilator interaction related to poor cycling time, the late cycle event. We say that the ventilator cycled the breath too late when inspiration ended after the patient stopped exerting inspiratory effort. In some cases, before the ventilator cycles to expiration, not only the patient stopped exerting inspiratory effort, but they may have also started developing expiratory effort. Let's look at a case. Using our systematic approach, we would identify that the patient is on APV, where the limit variable is pressure. We would remind ourselves of how passive waveforms would look like. Although we could start with a flow versus time waveform, in this case, it doesn't show us much more than that the patient exerts inspiratory effort through inspiration, as we can infer by its concave down shape. Looking at the air pressure waveform, note how a passive waveform would look like in the dotted blue line. The ventilator was given 5 centimeters of water, as shown in the right lower corner, above a PEEP of 5. Hence, the air pressure would look like a rectangle with the peak inspiratory pressure at 10 centimeters of water were this patient to be passive. However, we initially see lower air pressures with the difference shaded in white representing the drop in pressures seen with inspiratory effort. Later, we see a rise in air pressures likely going higher than we would expect in a passive patient. Note that the peak pressure here is higher than the 5 centimeters of water the ventilator is applying above the set PEEP of 5. The reason for this late peak is likely twofold. One is that the patient inspiratory effort ended, so there's no more of the previous drop in air pressure secondary to it. However, that wouldn't explain pressures going higher than the expected peak inspiratory pressure. Likely, we're also seeing the results of expiratory effort by the patient, which raises air pressures. The treatment for a late cycle event would be to manipulate our cycle variable to shorten inspiratory time. Note how as we drop the I time from 1 to 0.7 seconds, the late peak disappeared. Although we see an early cycle event leading to double triggering, so maybe 0.7 seconds was too short for this patient. Let's look at another case on a different mode. We have a patient on pressure control. The limit variable is pressure. Let's pull here to the side a normal passive waveform on pressure control for comparison. When we look at the flow time graph of our patient, we see something interesting. First, we note that initially the patient was active, again, evidenced by the higher flows than would have been expected were this patient to be passive. However, we then see a period in late inspiration where flows stop and maintain at 0 for a little bit before the ventilator cycles to expiration. In pressure-limited modes, active inspiratory effort leads to positive flows. So this is a clue that the patient stopped exerting effort at the red arrow. Let's now look at the pressure time waveform. In the pressure time graph, we see that the patient triggered this breath and lowered air pressures early on, as compared to what you would expect in a passive patient. This is caused by inspiratory effort, which concurs with our prior assessment. At the red arrow, air pressures rise to their peak inspiratory level and maintain there, resembling now a passive waveform. This results from relaxation of inspiratory muscles. Both our analyses agree. The patient began the breath active and ceased inspiratory effort by the red arrows. Note that the red arrows come significantly earlier than the start of expiration, as marked by the yellow arrows. This is therefore another case of late cycling. Here, we decrease the I time from 1.1 to 0.7 seconds, and now we're not having those periods of no flow at the end of inspiration. Lastly, what if we diagnose late cycling in a patient ventilated in pressure support? Late cycling may happen in pressure support, as you see in this case, as evidenced by the late peak in air pressures. It is, however, not as common, since the cycle event, a drop in inspiratory flows to a certain percentage of its peak, is tied to a drop in inspiratory effort. If you wanted to shorten I time in pressure support, what could you do? Well, you could increase the percentage of peak flow at which the ventilator would cycle to expiration. In this case, we increased it from the default 25% to 60%, so the cycle threshold was met earlier. One final concept that is really important when analyzing waveforms in general is that not every classifiable patient-ventilator interaction is clinically meaningful. If the patient looks comfortable, you don't need to seek a certain waveform pattern. However, if the patient looks uncomfortable, or in the case of late cycling, is clearly trying to exhale during inspiration, then addressing the patient-ventilator interaction becomes important. One additional advice that I have is when you're assessing these interactions, it is generally a good idea to rest your hand on the patient's chest or abdomen while looking at the ventilator. Your hand may allow you to feel the results of respiratory muscle activation as you look at waveforms. This is it for today. On next week's video, we'll discuss additional patient-ventilator interactions that are related to the trigger event. I'll see you then.